Good afternoon. So this is the regular monthly performance review that I'd like to take you through today. Just to review, you'll recall the background, the ALC discussion, ED performance, and I'll be covering also today the 2008-9 MLOT performance. So it's in effect a quarterly, but it's our fourth quarter, therefore our annual, the final report card we got for the year from the school, sort of thing. We've walked through this before, but I'll just go down them again. Performance measurement is seen as a cornerstone of improvement. If you don't measure it, you don't track it, you don't work on it, what are your chances of improving it? We still are looking at sectoral measures rather than system measures, although we know our goal is to improve the system overall. Primarily, we follow the MLAW, the Ministry Lynn Accountability Agreement, because that's our accountability back to the ministry, the love, honor, and obey part of the contract we have with the ministry. Our measurements are all compared to the targets, and you'll see that those change over time. As you recall, we tend to have compressed trends to make the data so it's more understandable generally. And also just to keep in mind that although we're only looking right now at January data, come September or so, we're going to see a new process for the way we do wait times, so the mechanism will be different. Here is our weekly Erie St. Clair Lynn performance in terms of ALC. You'll see we're running out to basically last Friday, so that's how current the data are. You'll notice how the line breaks like that. That's because in this year, our targets dropped. We were at 10, we're now basically 9.5%. So that's why I'm showing the break in the line. So as we go along, eventually that line will be the only line, this line will disappear. So, yes, our target, because it's part of the ministry process to improve the system. So one way to improve the system, of course, is to change your targets over time. And Gary and I, in fact, just had our negotiations yesterday, or begun them with the ministry on our targets for 9-10. And in many cases, we're looking at better improvements this year than last year, which was better than the year before. The goal, of course, is continuous improvement, because it's our healthcare. So, as you can see, now keeping in mind, too, that these are our internal numbers, so they're different than the final calculations from the ministry. But what's important to us is the trend. And what we see very clearly, very starkly, is you see that bump up in the last quarter. So that's January, February, March. So typically we know how badly off we are in the winter months. And there it is, right there, very stark. So you see, kind of stable, and then bang, right up. And you see very quickly just the month of April. So these have gone from quarters to just the month of April, just the first 3 weeks of May, dropped down dramatically. So there was a bit of a decline in March. It's buried in here, but we've come down quite well. However, of course, now our target's more severe. So we have a lot of work to do, obviously, on ALC over the next year. Looking at it by site, what you see is, by and large, the two Windsor hospitals are staying on target reasonably well. You see a dip. You see the increase here, more significant at Windsor Regional than it was at Hotel Dieu in the winter. So Hotel Dieu, for some reason, was accommodating better. You see, though, and this is certainly a challenge for us, is Leamington. Small facility, over our whole numbers, it doesn't have a huge impact. We're not sensitive to what happens in Leamington, but obviously people in Leamington are sensitive to what's happening in Leamington. So we have a lot of work to do. Pat will be discussing that in her little presentation shortly. So Leamington is a special concern to us. They've gone up, as you can see, and they haven't come down. That's not good. The other two facilities, you see Blue Water. You see that even though overall we have a challenge in the winter, and we know we always will, there's been a lot of energy put into Blue Water. Pat's been out there, Paul Brown, our account manager, other staff have been involved in helping them with the CCAC and the other providers to help bring Blue Water down. And as you can see, that's definitely a good trend for Blue Water. So we can make a difference. We just have to put the energy and the time and the resources into making it happen. We see then CKHA, and as you can see, very stable. Certainly a site that has managed patient flow very well. A lot of lessons to learn, obviously, from that site. Well, you recall that at the last meeting I mentioned to you, would you like to see what the financial impact is of ALC? So called, it's Keeler's word, the notional cost. So this is where you say, okay, an acute care bed that's ALC costs about $900 a day. A long-term care home bed costs, last year, actually $133.75. So if you've got someone who's in an acute care bed, but needs to be in a long-term care bed, you do the math. You subtract the two numbers, you've got a cost per ALC. Well, the same sort of numbers and things happen if you're in a rehab bed, an inpatient rehabilitation bed, or in a complex continuum care. The old term is chronic care bed. You just do the math. So if you're in a rehab bed, but you belong in a nursing home bed, what's the difference in their cost? You roll all the numbers up, and you end up with a very simple way to see the impact of long-term care just in the hospital. So this excludes people who are in a long-term care home, who could in fact go home. Now, they may have sold their home, that's certainly one issue. But the point is, we know there are people in long-term care who have improved and don't need to be there. We just don't know what the numbers are. That will become shortly. Yes, David?
I know that this is notion. I really like the word. But numbers are somewhat seductive. So is it possible that you could add up the ESC Lynn quarterly costs and it would be in the neighborhood of $140 million annually?
Sorry. No, this is a good point, David. Sorry, I should have put that on the slide. This is the annualized rate in each quarter. Or each period, sorry.
Okay.
Yeah, sorry. I'm selling this.
Fair enough.
So what you see here then, so you're able to compare quarter to quarter.
Yeah.
So just to recall, we get the data from the hospitals on a weekly basis. So we know every Friday what's going on. Well, look at that as one day. Then you just do the math.
Sure.
So let's say you roll it up. So what you see is, you see, for example, the impact of the Leamington's challenges on the system. A relatively small facility, but the effect last quarter, 10% of the dollars. Fairly significant. You see also the rise in time. So that last quarter, we had to bump up because of the winter. That's $5 million is what it did to that annual change. So can we save this money? Not directly. Is it worth putting resources into better systems to improve ALC? Yes, it is. Because not only do you help people, but you also then help the system because you make better use of the dollars we do have. So that patient flow issue becomes really substantial. So for example, we look at these numbers and we look at a tool that does bed management for our hospitals. And if we spend $1.5 million over 5 years to help us understand and fix a $40 million problem, that's probably, and that's annually, that's probably a good trade-off. So you can look at the numbers that way, but we can't go to someone and say, thanks for the check. It doesn't work like that.
Sure.
Any other comments or questions? Thanks for picking up, David. That's my fault. I'll flip then to the ED length of stays. So as you see, I'm showing you here the monthlies because this is when the data set began. It began last April. So as we get a couple more data sets here, we'll finish off the year. Then we'll start doing the quarters and roll that up for you. But what you see here then is for Erie St. Clair, how we're doing on our admitted patients. So what you see for high acuity admitted patients, we had a decline, a curve up. So our baseline is about 8 hours. We're certainly higher than that. So we have work to do to get that number down. If you look at low acuity admitted patients, the target is lower. Non-admitted patients, and you see we're also slightly above the target there as well. So we're not doing well on either of those in terms of the target. In perspective, we're doing much better than most of the province. But we're not doing well to the provincial target. So work to be done. Looking at it by hospital, a bit more spaghetti. What you see here is the high acuity line for Erie St. Clair. Then you see our 3 hospitals. So you see that Windsor Regional, which is the facility that receives the pay for performance money, called pay for results, P4R, they're basically doing quite well. little dip up in that last January month. It may come down. We don't know, of course, that yet. What you do see, though, is that Leamington and Hotel Dieu has stayed above the line. You see Leamington has had a spike. So, again, challenges in ER, another way to see them in Leamington. Again, we sort of apologize for the spaghetti, but it also helps you get a feel for where we are in Sarnia, Lambton, Chatham-Kent. And as you can see, all of the providers are below on high acuity, a good thing. So everyone's doing well. And you see the month-to-month variation. The only challenge might be what's going on in the Mitten site, just because it's coming up in the last few months. We'll have to watch that one, of course, closely. Looking at low acuity being the CTAS 4s and 5s, the non-urgent and deferrable patients. What we see here is that Leamington is quite high, and they're a high volume provider of that service. You see that Hotel Dieu is next, and Windsor Regional, where they're getting funding, they're quite close to the line. So the good news is that the low acuity patients weren't spiking up at Leamington as they were for the high acuity patients.
Brad, there's a question.
Sorry, Lila.
I'm just noting the high acuity, Windsor Essex, it appears the baseline is different than it is for Sarnia Lambton. Sarnia Lambton shows 8 hours, and Windsor Essex 9.
You're seeing this one here, and
The black line. Is there a reason?
you're right. That line, yeah, sorry, but thanks very much. Yeah, Leland, that line, for some reason when we reran it, that belongs down here. So that we've thrown you up on the benchmark. I'm sorry, I didn't notice that. So that line should be 8 hours. So when we reran the graph, this is a manual, you got to do a manual change. We didn't make the manual change. So that's our mistake.
Thank you.
Good eye, thank you. So there we caught it. 4 hours. 4 hours. Yeah, so we missed that one on the screen. So the last one, looking at Sarnia, Lambton, Chatham-Kent, low acuity, lengths of stay. We see the only site that's over the line a bit is in Chatham-Kent. So they have a challenge there on low acuity lengths of stay in Emerge. Something actually we mentioned to them yesterday. Whereas the other 3 sites in the area are below the line. So you'll recall the discussion from the Wallaceburg residents about length of stay going to CKHA for care. There are the numbers. Because we're talking primarily a low acuity volume, 4s and 5s, and it's certainly got a longer length of stay than the target, and it's better in Sydney. Of course, it's even better in Petrolia and in Sarnia itself. I'll move on to the next section of the presentation if I can. This is our 4th quarterly AMLA report card. So that's why the format is different. What I've done is I've just abstracted information off the main ministry template that they send us. And you'll see over here on the right-hand side, basically a report card. So there are 11 indicators that we are responsible for in our Ministry Limit Accountability Agreement. The 12th one, cardiac bypass, of course, we don't do that here. Our patients go elsewhere for that service. So we have 11 indicators that we're tracked on. And as you can see here, we were within the performance corridor. So you have to hit a target plus or minus a range. We were within those performance corridors on 10 out of the 11 categories. Yes, David?
How wide is the range?
It depends on which category you're at. Some are much smaller, like 10%. Others are larger. We have all the information, so we can provide that to you, obviously.
Just the reason I ask is the hospitalization for ambulatory care sensitive conditions
Right.
Seems to have a pretty wide range.
It does, because it's such a hard measure to control,
Okay.
because it's so heavily related to primary care. In fact, that's one of our challenges. Yeah, thanks.
Yeah.
Just as Laura was saying, we're so short of GPs. It hits us in ambulatory care settings. People who could be treated in a primary care setting, they get admitted. People who could be treated in the primary care setting could be managed elsewhere, but are in our emerge departments. Also, quite a high number. See where the province is, see where we are? Mm-hmm. We have a much higher target because we begin so strapped for primary care. It also affects our readmission rates for heart attacks. Same thing happening as well. You don't have a referral back to primary care. You just get readmitted to the hospital. So certainly 3 huge challenges related to primary care. What we see here is that we, in a sense, failed on our report card on 1 out of the 11 items. So we got, in a sense, 91%. That's why I talked to staff about it. So here are then some of the results of that table. We hit 10 out of our 11 targets, 91%. That's the best record of anyone in the province. Exactly. What I want to say and make it really clear here that we didn't do that, other than if you look at the we as Erie St. Clair. This is a combination of providers, nurses, and doctors, and clerks who do the recording of wait times because we had a difficulty with data. So it goes right down into the bowels of all the facilities, right up to the OR, to the nurse, to the doctor. So it affects, it had to involve a lot of people to make this happen. It involved the ministry because they were providing specific funding to make this happen. And I want to say publicly a special word of thanks to a fellow named Pete Servant-Kosky, who works for you, who basically is the one who owned and lived this and just did an outstanding job. You can ask Pete virtually anything arcane you want to ask him about this, and he'll give you an answer. And even if he's wrong, he won't question it.
He's that credible.
He's that good. He just does an amazing job for us. And so when you go back to the others, just to reinforce, ambulatory care sensitive, care managed elsewhere and emerge, readmits, those are 3 categories that heavily are affected by primary care services. Very difficult for us to change because our window is so small in that world, and the world is in such difficult straits, as Lori told us earlier. As I mentioned, the median time to placement one is our failure. Be simple, it's a failure on the report card. That's heavily linked to funding for care at home. 2 ways to solve the problem. One is to build more long-term care beds, but that's not what I want for my father. The other way is aging at home, to provide more care at home. And the issue here that we've identified is it's heavily related to exceptional circumstances or specialized funding for additional hours of care at home beyond the normal amounts of care provided. The CCAC had a real bonus a year ago, and they reduced their ALC last year. You'll recall that we were the only part of the province that came down a year ago. We had the money, we spent it well. This year we didn't have the money, it wasn't there to spend. So we didn't have access to that funding. The ministry has given us additional funding for this coming year. We need to apply that quite well to ensure this happens, rather than build more beds, which we could say is easier.
Also building more beds.
We could do that as well.
We are building more beds.
Yes, we are. But our focus would be, if you'd like to help you stay home.
Okay.
That's the goal we want to go for. We've done much better than some leagues. For example, although we failed here, our achievement was still the second best in the province. So it was not an easy target to hit, and we were still the second best, although we failed. They also failed. But that's part of the challenge. So they aren't easy targets. They're based in part on each limb and where you are and where you need to move to hit a provincial goal. They improve each year. Your question, Nina. They will change each year to get better, because that's the job of the system. So can we do better? Yes, we can. And as I mentioned, we're now negotiating with the ministry for our new targets, and we'll be getting back to you in June with those proposals. Any comments or questions about the report card?
You just mentioned, Brad, like fathers who age at home.
Yes.
There is going to come a time when I don't wish to stay at.
That's true.
Or I become unable to stay. And I would kind of like to know if there's some place other than at home.
My dad feels the same way about it. He does not want to live with us. And that's true. The point here is, the sad fact as I see it, Keeler's view of the sad facts, is in terms of this situation, part of the reason you get on the list for long-term care home isn't because you want to be there. It's because there aren't services in the community to support you at home any longer. That's the not having the money for special circumstances. And so that's right. If the patients come to a point where we're doing the best we can in the home and that failure to thrive is there, that's right, because they're not going to be compliant at home. You want to have that option available to you. But right now, our limitation appears to be we don't have the funding to allow you to stay at home if you wish to. And you're right, you're not trying to drive anybody anywhere.
Oh, my dementia has gotten so bad. I need help.
Oh, that's
a distinctive.
but you forgot. But yes, you're right. The issue is, how do we give you good, fair choices? And if we have the resources in the right spots to allow you to have those right choices.
So he wants to know that there'll be a long-term care home for him when he needs it.
There will be. I would suggest, say there will be. You may have to spend some time in a complex continuing care bed, or in a hospital bed, or at home with less services you need to get there right now, but that's what we're trying to fix. So there is the right spot for you at the right time.
Great, I'm up there.
Any other questions or comments for Brad about this part? We're going to hear more about the M-lines. No, Thursday.
I think the next presentation is perfect. It's Pat. Just to introduce to you, Pat Pearce is our ERALC performance lead. Pat just joined us back at the end of February. She comes from, you will never guess where she comes from. I'll let her speak for herself. Her background is, in effect, my view, 10 years ago, Britain was going through the same process we're going through now in terms of trying to reinforce community services. And Pat was there as that was developed and has been very successful in doing it. So, with that background, I'll turn it over to you, Pat. I don't know if you want to
Okay, that's done a really good job of introducing me. I wanted it to be a surprise when I spoke on Hay. Yeah, my background is in mainly in community healthcare. I'm a nurse practitioner by background. Following on to that, being director of community services and part of developing primary care trusts in the UK. Since coming to Canada, I first landed at the London Lynn for about 6 months, and then I arrived in Windsor with my husband. So I ended up as Director of Patient Navigation in Windsor Regional. And then, through good fortune, I ended up here. So I met Brad and the team, and I've been really happy since. I just wanted to get that plug in. I live in this town. Now, just going back to the stock take report, I'll be very brief going through this, so please, ask questions when needed. The background to the stock take report, really, for me, it was a ministry, it's really the ministry's way of taking stock of what's going on in All In, or in the province really, but in particular for us it's for All In. And what we're responsible for is preparing the data and then presenting it to the ADM Canteen. So it's a quarterly evaluation of what's going on in All In, what projects are we doing, what are the issues, what are the challenges, and basically that's it. And then it's prepared by a team, not just by me. I mean, I've inputted quite a bit into it, but I must give credit again to Pete and the team in All In. Canteen meets quarterly with each of the CEO, who then presents it to him to review. And then what I'll talk about in a minute is the process to date and the corrective actions we're going to take And I think what we need to hone in on here is the word action. It's not actually about finding out what the problem is, but it's about how we did something about it. The stock take, you'll be able to view the stock take report in all its glory on the web. It's posted to the ACLN web. There'll be a quarterly review of the hospital, CCAC and CFOs, and it'll be used for the staff for education purposes. This is the first page. I didn't really want to bore you with all the how detailed it is really. It shows you the 3 main areas here. This is the provincial overview of the 3 areas, and these are 3 goals. Part of my job, as Brad said, is the ALC lead for the LIM. So for me, this drives what I have to do. The first one is looking at reducing ER demand. The second is to increase ER capacity and performance. And again, the big one, which is very close to my heart really, because it deals a lot with our elderly patients, which is bed utilisation in the hospital. Not wanting to keep patients there, we don't need to be there. Okay, I'll just take you through now. Actually, beside the stock take report, we prepared 3 charts for Gary to present to the team. So the first one was reducing ER demand. Now, we'll try to keep it as simple as possible. I've showed you here what the issues are, what we've got in place at the moment that should be addressing these issues, and what's planned for the future. Now, how I got to this, or how the team got to this, part of my role when I come to the LIM was to actually walk the floor. So I walked the floor of the 5 hospitals, and I found that quite a really good experience, particularly from being a clinician, to see how hard the work and each of the areas, there was different challenges. There was an awful lot going on that was positive, and what I had to do was try and see through all this and see how we could take that forward. Now, particularly in reducing the ER demand here, for me, we've had the presentation from Laurie, particularly about being under-serviced with physicians. That was quite evident, particularly in the ED department. Using GPs, using Health Force Ontario, or using GPs that just paid for going in to do this, that particular shift, which is quite demanding really, because sometimes they don't know the staff, which is quite key when you're working in an ED department. Conditions that could be managed elsewhere, that's really evident. For me, these people are pitching up at our ED department should be managed out in primary care. Sorry, I can't see that very well. What was the next one? Frequent visitors, failure to cope, and social admissions. We've got an awful lot of families in Ontario, same as the UK, that are trying to cope with elderly parents or relatives. And really, it's actually the carer that fails to cope more often than not than the patient. So they don't know what else to do with that. The wits end, they pitch up at ED. And these are the ones that I feel really should then be helped to stay at home but with care. We need to give our carers more support and try and give them respite. So what's happening here, the other side of the chart there, we're an awful lot of mental health issues pitching up at ED. They're not being managed appropriately within the ED because they can't. They really should be, managed outside of the ED department. So if you look at your chart, there's a number of initiatives now in place that we're trying to address this. So what we're going to go to is to increase ED capacity and performance. What I found here was there was 2 areas. We've got one good performer, which is actually Blue Water Health. Their wait times in ED, and when I walked into Blue Water Health in the mission site, it's an old facility, very old facility, very tight sort of situation. From somebody that's worked in the ED department, I was actually horrified when I walked in. I thought, how are you doing this? Well, how they're doing this is good management. But you've got a team of doctors there that are working very tightly together. They've got an excellent patient flow through the unit, and I was very impressed with the high acuity patients. The problems there, it's not with the ED wait times, it's getting them out of the ED because there's no beds, and we do have a problem within Blue Water Health because there's no beds. But with saying that, their wait times are absolutely superb. So we've got a lot to learn, and I think what we have to learn from Blue Water Health, this team, is actually the team approach to dealing with patients, and the way we care for patients is excellent. We'll put this down as poor performance, but I don't see it really as poor performance. It's only poor performance because of the figures. But actually, everybody is working extremely hard in Hotel Do. And there's a number of issues there. Again, mental health for CTAS 4 and 5s, admitted patients, which really shouldn't be admitted into an acute care bed. We should be looking at more appropriate places to put our psychiatric patients. So there is some projects planned here. The psychiatric assessment nurse going over to patients from long-term care homes. We've got nurse practitioner outreach team will be starting soon in both Windsor Regional and Hotel de Grace, which will reach out to nursing homes, start an education process, and look at prevention of admission. And we've also got the Gem Nurse project, which is being spread out across the lane, so we'll have 2 Gem nurses actually in each emergency department, which will be excellent. Our other problem was that, quite rightly said before, is Leamington. They're not a big hospital, there's problems there, and one of the issues is end-of-life patients. Particularly not palliative care patients, because you must make the distinction here. Palliative care, if they go pitch up at hospital, are there for acute needs, but end-of-life patients really should not be coming into the emergency department and being admitted. I think there's much better situations. If you don't want an IV put in their arm, you shouldn't be doing that with end-of-life patients. It should be a whole end-of-life process that happens with hospice or particularly hospice-trained nurses. Frequent visitors, the same again as all the ED departments really. These are patients that could be managed elsewhere. So goal 3 is bed utilisation. I found here again, there 3 areas that are really not very good at it, which is Leamington and Blue Water Health, and for different reasons really. Emergency department diversion. If we could be diverting a lot more patients from the emergency department, we would not be ending up as ALCs. These are your patients failure to thrive, failure to cope, social admissions, patients that could be managed elsewhere, elderly patients who are being admitted. So that has a big impact on the ALC patients. Another issue was around Blue Water Health. For both these areas, Leamington and Blue Water Health, the one thing that I found was actually the patient flow. It really wasn't what I would deem as good enough, only because of the systems, and I think Brad touched on that earlier. So I'll just flip over to actually Chatham-Kent Health Alliance. I mean, I was very impressed when I worked with the 2 nurse reviewers there. And one of the systems they used was a system called MedWorks, which has a critical care, a sort of an acute criteria that assesses patients from day 1. So as soon as they pitch up on the ward, we know what the discharge date is, we know what the barriers to discharge are, and they're addressed right away. So their actual throughput is excellent, but they've got the tools to do the job. And I have to say, Blue Water Health, Leamington, and even Windsor Regional and Hotel Do have not got that tool yet. So before we start anything else, we need to address the systemic processes that are going on in these hospitals. So by the time we got to the end of this, my thoughts were we can sit and talk about it, we can put some projects in, but is that the right thing to do? So what we really wanted, and with the help of the team, we developed the Rapid Improvement Event, which I think, or I'm sure Gary will be able to tell you this, that Kendi was quite impressed by this process. Because what we want to do here is not just to say, what's the best project to work on. Let's look at it from a broader perspective and do it in 90 days. Let's get it off the ground. Because this stocktake report, I have to ensure that gets ready for Kendi within 90 days. So I want the issues that were raised, I want some action, and I want some, to actually have a result for Ken for the next, it's not going to change dramatically, but I want him to know that we're actually doing something about it. So what I'm doing at the moment with the help of one of our senior planners is getting together what are the issues, and we're sorting out, any mitigation strategies in case we can't do them. So our cycle is plan, do, check and act, and this will continue 20 days on each of these areas. So you can see that we're not actually just talking about it, we want to do something about it. So thank you. Any questions?